Hello, everyone, and thank you for joining us on this evening's podcast. With us today, we have a very special guest and friend, Amy Butterbaugh. Amy is the Clinical Director and Patient Outreach Advocate. She is an expert in palliative care and has served as a critical advisor to various hospice and home care agencies. So thank you for joining us, Amy.
Thank you for having me, Marcia.
So the first question I guess a lot of people would have, and when you're meeting with them in the patient's home, is how did you get into this industry? What has been your experience? I mean, we're talking about hospice care, so obviously we're not seeing someone, right out of nursing school, and you can talk a little bit about that, get into hospice care. So how did you start?
Well, I'm a registered nurse, and I was doing some work in home care, specifically infusion. I was in a nursing home seeing one of my clients, and while I was there, I was overhearing a conversation between a director of nursing and a hospice sales representative, and it piqued my attention. So that evening, I went home and I read the regulations for hospice care, and I applied for a hospice on-call job, got the job, and never left hospice since then.
So from your experience, what is the biggest misconception about hospice care or palliative services? And maybe define for us and the viewers, what is hospice care, what is palliative care, and what are the differences? Because I think a lot of people, especially if they're not familiar with the continuum of care, if they're not familiar with home care, they're not really familiar with those terms. And so a lot of times, when they have advocates, especially in the hospital setting, say hospice or palliative care, they're not quite sure what that means. So,
okay. Hospice care is for somebody that has a condition that could limit their life to 6 months or less if the disease runs its normal course. They have elected away from aggressive treatment, and they have elected for comfort measures only. Palliative care is for patients who have a condition that requires symptom management. They don't necessarily have to have the 6 month or less limited life expectancy, and they have to have a symptom that needs managed, whether it be pain, nausea, vomiting, seizures, something that you would manage. Hospice care is billed under the hospice Medicare benefit. Palliative care is billed under the home health benefit.
So palliative care, when we're talking about needing palliative care, what's the typical scenario when someone would need palliative in real life examples versus hospice care? Patient scenario.
A good example of somebody needing palliative care, possibly they have a cancer and they are still receiving chemotherapy, but they have a lot of symptoms from the chemotherapy treatment. So they could have some pain, they could have nausea, they could have some seizure activity. So palliative care would be a good service to help them with their symptoms during that treatment.
Now, would this patient then turn, you had mentioned something about home health. Would this patient turn to a traditional home health provider, or is this still a hospice type patient?
Under palliative care, they would turn to a home health care provider.
And that would be for symptom and comfort measures and without a specific 6 month diagnosis?
Yes.
Now, when we're talking about traditional hospice care, we're talking about a patient with a 6 month diagnosis. Is this something that we're seeing more frequently in the transitions of care where patients are able to go on hospice and then eventually maybe come off of hospice depending on their treatment?
It is. Hospice years ago was not as utilized as it is today. Physicians are now able to be reimbursed for talking to families about hospice care. So the incidence and the utilization of hospice care has increased greatly over the past 5 to 10 years.
Now, traditionally with hospice care, from my understanding, and again, I apologize if I don't know a lot more detail, I know, and I know a lot of the viewers probably don't know, that hospice care can transition into the home because we talk about community-based services, we talk about community integration. When we're talking about traditional hospice, we're not talking about facilities, am I right?
Hospice can be done anywhere.
Okay.
So we go to patients' homes, we go to personal care homes, assisted living facilities, and we even go into skilled nursing facilities. We can also provide inpatient hospice care within hospitals.
For family members, what have you found to be the hardest conversation? I know that you work with a very much educated, experienced team, but still that conversation is very difficult because from my understanding, hospice has always meant end-of-life measures. What do you find is that conversation like, and what would you suggest to families out there that may have a need for hospice? What are some of the resources and what conversations do they need to have with their loved ones long-term to decide whether or not hospice services are right for them, or if it's palliative services or home care?
One of the things that we do when we go out and talk to patients about hospice and their families about hospice is we educate them about the services that are available. Oftentimes, in educating people about the services that are available, it helps them see that they have a need for the service, because when you start talking about the symptoms that make somebody eligible for hospice, they oftentimes think in their mind's eye that, yes, my loved one has this, and yes, we do need this service. Going on to what we could do to help families, when the patients are on hospice, after the patient dies, we send out family satisfaction surveys on the care that the patient received throughout their hospice stay. One of the number one things that are always mentioned is, I wish that I would have known about this sooner. So getting that education and awareness out there and working with the physicians to get patients identified for hospice more quickly and sooner in their disease progression is a great thing, and it definitely helps the patients and the families.
You know, one of the things that I've learned recently is that hospice does not just include your traditional pain or comfort measures from nursing. From my experience, and maybe you can tell me more about that, you would contract with rehabilitation companies and send out therapists. How does that play into hospice now, in 2015?
Well, hospice is an interdisciplinary team. It is comprised of the hospice medical director, who is a physician. It's comprised of the nurses. It's comprised of the home health aides, the social workers, the chaplains, the hospice volunteers, the therapists, being physical therapy, occupational therapy, and speech therapy. When a patient is on hospice, we cover all the meds, supplies, and medical equipment related to their hospice diagnosis.
And when we talk about social work and volunteers, what are some of the services available to family members, maybe not the patient directly or the participant, but family members, maybe even following or throughout the progression, obviously, of the disease, and maybe following the passing of the family member?
Well, with the hospice services, we treat the mind, the body, and the soul. So we provide the physical, medical care, the emotional care to the family with our social workers and our bereavement counselors, and then the spiritual care comes through our chaplains.
When you look at hospice as an industry, where do you see hospice belonging in, again, the transitions of care? Because we talk a lot about that right now. We talk a lot about the health reform. We talk a lot about what's happening in nursing homes and the various programs that are available through waiver. Where do you see hospice in Pittsburgh in 5 years, and how are we going to see it incorporate more into the community model?
I think with the way that healthcare is going, hospitals are reducing their rehospitalizations, so patients are being forced to have more access to community services. I think that the utilization of hospice is going to increase. As I said earlier, the physicians can now bill for talking to patients and families about the services. So I think there's going to be a greater educational awareness and utilization of the services. So I think that the number of patients getting hospice services and benefit from it are going to grow.
In my experience with home health, traditionally, we've worked and we've partnered with you to provide services for patients on the transitional level. We've had patients that have received home health services in the home, and without being hospitalized or staying in a rehab facility long term, they were able to receive hospice, and it has been a very smooth transition. Traditionally, although hospice has been a referral from a nursing home or a facility or even a hospital stay, what would you advise to families that would like to have a hospice consultation without contacting their physicians? Or do you think it's beneficial to go to the physician directly?
Well, oftentimes it's good for the physician to be on board because you never want to have a hospice company calling a physician, introducing hospice services to that physician. Oftentimes they are very surprised when they get those phone calls. So it's good to have everybody on board, the patient, the family, the physician, and that way it's a team effort.
And what would your approach be to talking to the physician about these services?
We usually identify the symptoms that we feel make the patient appropriate for hospice and then discuss that with the physician.
I think that hospice is very much necessary in what's happening in the community, and I know that you would agree 110%. I think that the utilization of hospice in the continuum of care and in the prevention of hospitalization and ensuring that someone can stay in the community, which is ultimately the goal for everybody involved. And I know that I run into a lot of non-medical patients, and the unfortunate part is with every hospitalization, it becomes more difficult to recover independently. And I think the system right now as it stands is designed to keep a patient out of their home, unfortunately, and in rehab for a longer period of time. And so they can't always come home to get better. So I think it's important for families and for our viewers to really understand that these conversations need to happen well before a diagnosis or well before a hospitalization, especially because we need to be talking about these issues before there is a need. And I know that with the services that you offer, and I know you're constantly advocating in the community that we need to have this conversation, it's to be more open-minded to what exactly hospice is and what it means to continue to live independently at home. So I really appreciate you coming and talking to me and the viewers, and I'm sure we're going to have follow-up conversations and talk about everything that's happening in our landscape. And I really appreciate you sharing your experience with the viewers. You bring a lot of years of experience to the table. You're very passionate about what you do. You love to take care of the patient, and most importantly, reach out to the family. So I appreciate everything. Thank you so much, Amy. Thanks for joining us. Thanks. Bye-bye.